You're watching CTOM TV. Knowledge is power.
So, do you want to start us off, though, on your list of topics?
Sure, I've made some notes here, too. I had to revise my notes because I haven't been over chemotherapy in a long time.
Yeah. Well, you focus on
targeted therapies.
Yeah,
we don't spend a lot of time. Usually patients come to us after they've already had,
basic
their
therapy.
Chemotherapy.
Yeah. And maybe that should actually be kind of illuminating for you watching at home, which is that here's a leading edge cancer care expert who so rarely recommends or works with patients who he suggests cancer chemotherapy for.
Mm-hmm.
That he's having to kind of do a little bit of backing up the bus and educating.
Well, definitely, I think genetics and genetic testing, tumor DNA sequencing can really help us understand which chemotherapy agents are going to be better for a person.
Mm-hmm.
So we definitely spend a lot of time with that,
Mm-hmm.
and without a doubt. That's something that we do spend.
You definitely look into. Is chemotherapy going to benefit this person, and if so, which?
Well, chemotherapy is the standard tool for treatment right now. It's what oncologists are trained in, and there is a continual flow of new information related to genetic alterations in regards to how they affect chemotherapy.
Mm-hmm.
In other words, why does drug A work better on this patient than drug B who have the same type of cancer?
Mm-hmm.
And when you look a little deeper and you peel away some of those onion skins, you see that it's actually the mutations. Mm-hmm. So we spend a lot of time looking at mutations in patients to determine if they're on the right chemotherapy, mm-hmm. and if not, what chemotherapy agents would be better for them. Mm-hmm. It's a big part of what we do. We mm-hmm. spend quite a bit of time with that.
Mm-hmm. Because aside from the most important thing to do with cancer care, which is being on the right treatment that's good.
This is beyond precision oncology. This mm-hmm. is what we call, precision chemotherapy.
Okay. Okay. So thank you for correcting me. So as part of what you and your team do, you're definitely, because chemotherapy is still so prevalent.
It's a very important tool.
Right. So you're still looking at it, is there some way to maximize the benefit of chemotherapy for a patient?
Yes.
But then you and your team move beyond that and look at
targeted immunotherapy. Yes.
Right. And
it is directly unique to that patient.
Right. Yeah. That's right. So then it's a far more comprehensive treatment plan. And
mm-hmm.
Yeah. Okay. Thank you for clarifying that. So you go on ahead there. I'll get out of your way here.
So chemotherapy is literally any drug that is used for therapy. Mm-hmm. any sort of chemical combination used for therapy. What we're going to talk about today is what I like to refer to as traditional chemotherapy.
Okay.
And traditional chemotherapy is a class of drugs, and there's probably about 18 to 20 different subtypes of these drugs, many different drug names, but different. They're based on the mechanism that they use, but pretty well any sort of drug that inhibits the cell copying process called mitosis.
Okay.
Cell division. So traditional chemotherapy interferes with mitosis in some manner. And because of that, what they do is they target rapidly reproducing cells.
Okay.
They only target rapidly reproducing cells while they're in the body. So obviously, the longer an agent stays in the body, the longer it's going to affect any cancers that are rapidly reproducing.
I see.
The unfortunate side effect of that is that because they're rapidly reproducing, they affect a lot of other cells that are also rapidly reproducing, such mm-hmm. as the cells of the bone marrow, mm-hmm. The digestive tract, mm-hmm. and the hair follicles. Mm-hmm. And so the common side effects of interfering with the cell division, mitosis, mm-hmm. is you have decreased production of blood cells, mm-hmm. Immunosuppression because your immune system is in your blood cells. Mm-hmm. You can have inflammation of the lining of the digestive tract, mucositis, and alopecia, which is hair loss, mm-hmm. as you know. Mm-hmm. Mm-hmm. And so all of these are rapidly reproducing cells, and right. So they're healthy cells, but as far as chemotherapy is concerned, they act the same way as cancer cells do, and they're inhibited the same way.
So basically, years ago, how many years ago are we talking? Not to put you on the spot, I know dates are hard to keep in mind sometimes, but say what, 60 years ago, chemotherapy? Well, how long ago did we start chemotherapy?
Much longer.
Much longer. Okay, this is why I'm here, because I know nothing. I need to learn lots.
Well, one of the oldest class of drugs was based on mustard gas, and they discovered this, back in World War One.
Whoa.
Yeah, so that was a long time ago.
That was a long time ago.
Yes. So that was the first, original chemotherapy. But
wow.
I think doctors over, since the time of organized medicine have been always trying different chemicals, whether they're, iron or, toxic metals. There's always been some form of chemotherapy going on. It wasn't until the 60s and 70s when the target became mitosis, the cell cycle.
Okay.
And this is what we're referring to
Right.
as standard chemotherapy.
So before that, what was the philosophy?
Just applying a chemical that killed more of the bad cells than the good cells.
Okay. Now, that's still the philosophy.
Yes,
that is the same
it
philosophy.
just has a
It's
mechanism.
just we understand now why that works.
Yes.
Okay. So
And
the
it's
hope
interfering
is
with the cell cycle, mitosis.
So the hope with chemotherapy is that we're going to eradicate enough of the cancer cells to stop the growth of your cancer,
Right.
Without eradicating so many of those
Without
healthy
killing you.
cells you talked about, like in the
Yes.
digestive tract and bowels and skin and hair and things,
Yes.
so that there's still, enough of you to enjoy survival.
Exactly.
Right.
Exactly.
Okay. And that makes total sense why there's such powerful side effects with
Yes,
chemotherapy,
of
if
course.
that's what's happening.
Mhm.
Yeah. Okay. Thank you for explaining that.
So I'm just going to give you a bit of an overview of the different types of drugs.
Okay.
The first and most prominent type of chemotherapy drugs, standard chemotherapy drugs, are called alkylating agents.
All right.
An alkyl group it's a chemical group. Most common one that we think of is a methyl group. It's just a combination of carbons, hydrogens, arranged in a certain order.
Okay. So that's one type of chemotherapy,
Yes.
alkylating agents.
Alkylating agents.
Got it.
So they're the oldest group. And they are an actual, mustard gas was one of the first ones. It's an alkylating agent. And so what they do is they bind onto, so when you give someone an alkylating drug, what it does is it creates these alkylating groups, these chemical groups, sometimes methylation groups and so on. And they bind onto proteins and DNA and RNA. And so basically it's like throwing a bunch of nails into the blender and hoping they're going to bind onto something and stop the process. And that's what they do, is they gum things up.
Okay.
So they gum up the DNA.
Not very precise, but it can
it's
work.
not.
It's
It
like
can
the
work
cog in
very
the
well.
wheel.
Yes,
Mhm.
exactly. Cog in the wheel. Yes.
Mhm.
So, stopping those cells for recycling. The important thing about alkylating agents is while most chemotherapy agents are dependent on a certain phase of the cell cycle. So the cell cycle, the reproduction of a cell, the copying of a cell has various cycles through mitosis. So alkylating agents are not affected by which part of the cycle the cell is in when you get the drug.
Mm.
So for example, one cancer cell may be in one phase where it's copying the DNA, another one may be separating the chromosomes, another cancer cell may be actually into dividing the cell, and there's all these different phases of the cell cycle that you learn in grade 8, grade 9 biology. And we're not going to go over that.
No, thank you. I didn't learn
So these alkylating agents are not affected by what stage the cell is in, whereas the other ones typically require the cell to be in a certain stage for them to affect them.
Okay, so they work on on the mechanism of a certain stage.
Right,
Okay.
whereas alkylating agents don't.
Right.
They're independent of
Got
that. Yes.
So was that after the mustard gas and the kind of the shotgun approach? This was
alkylating agent is mustard gas.
Oh, it is.
Yes.
Okay.
Yes.
So this really kind of was the first type, or
Yeah, the
Oh.
first one of the nitrogen mustard gas was the first.
Okay.
Yes. So there's basically 5 different subtypes of alkylating agents that we look at,
Okay.
and they are nitrogen mustard gases, and a common one is cyclophosphamide. I remember that from my first year biology. We used that, and then nitrous ureas. A common one is lomustine.
I'm not
the-
writing all these down.
No, the
That would be
tetrazines, and tetrazines are a very important class of drugs. One of them is temozolomide, TMZ, and it's very, very important drug for glioblastoma multiforme, and it's quite a tolerable drug. It's a good drug to have. So that's a drug that is commonly used quite a bit. Then there's aziridines, and then common one for that is called mitomycin. And then finally we have the platins, cisplatin, carboplatin, oxaliplatin.
And these are alkylating agents still?
Yeah,
Okay.
they act as alkylating agents.
Oh, okay.
So the platins, as you know, have the metal platinum in them, which is found in catalytic converters of cars. And the reason it's used in catalytic converters of cars is because it's able to bond large amounts of hydrocarbons and hydrogens and so on. And so the platins do the similar thing, but in
In your
cancer
body.
cells in your body. Yeah, so they're like a little catalytic converter in your body,
Cool.
cleaning things up.
Yeah, I'm picturing a vacuum or something like that,
Yeah.
Wow, okay.
So it's important to understand that the different classes of chemotherapy drugs, some chemotherapy drugs can fit in multiple classes. So they'll have multiple functions, they can be cross-designated. So it's not a limited system of
Understood.
classes and
We
groups.
won't hold you to the perfect stratification.
Thank you. So those are the alkylating agents.
Okay.
Now, then we have the antimetabolites, and there's typically about 4 or 5 different subgroups. And so what they do, as the name describes, is they impede the synthesis of DNA and RNA in the cell as it's reproducing. So because of that, they're dependent on a certain cell phase, and that's the copying phase. It's known as the S phase of the cell cycle. So when the DNA is being copied, so there's going to be extra copies so the cell can separate and both cells can have an equal amount of the chromosomes. That's the process. The copying cycle is when these antimetabolites work.
Okay, but again, they're working on all the cells, even the good ones that we want to
Yes,
have reproducing.
Exactly.
Okay, but that is what they do. Okay.
Yeah, but they're unique to that cell cycle.
Okay.
And so they are typically kind of like a Trojan horse in a sense. They form similar structures to the building blocks of DNA and RNA. So it's like taking a piece of DNA and putting in one of these anti-metabolite drugs that looks the same. So the DNA and the RNA will actually incorporate these drugs into their structure. And then once they do that, they can't be used. So it's like a Trojan horse effect.
Okay.
And so, they're typically incorporated into RNA and DNA.
And does that then trigger the death of the cell? Is that?
Yeah.
Yeah. Okay.
Pre-programmed cell death, apoptosis. And so as I mentioned, there's 4 different classes of these. There's the antifolates. Common drug is called pemetrexed, used for lung cancer. It's very effective. The fluoropyrimidines. Pyrimidine is part of a DNA. And they're fluorouracil and capecitabine, also known as Xeloda. And then there's deoxynucleoside analogs, and those are cytarabine and gemcitabine, common ones. And the thiopurines, which I don't see a lot of those. I believe the one with captopurine. And so this purine is also a molecule that's involved in the biosynthesis of DNA and RNA and so on. Yeah, and then we have the different class of drugs called the antimicrotubules.
Okay, this is class 3.
Yes, a 3rd class, yes. Yeah. So this requires a bit of an explanation, and I do remember this still from my first year biology because we did some experiments on this. So what these are, so in order for structures and chromosomes to move around the cell, we have this intricate system of what we call tubulins. And these tubulins are composed of some little Lego blocks called alpha and beta tubulin. And what they do is they form these long structures like hairs. They're almost like biological cranes. And they form so fast that they move things. And then they disassemble so fast that they can pull things around. And so when this chromosome needs to be moved over here or pulled over here, all of a sudden this alpha and beta tubulin quickly form this tube attached to the chromosome, and they grow. And by growing, they push it out. So they kind of like a stem of a plant.
Right.
They function, and these are what happens in the cell. There's a wonderful video on this a few years ago. It was one of the first real animation, flash videos years and years ago, and it showed the actual alpha and beta tubulins growing and moving these things, and it showed dyneins and kinesins walking proteins along these tubes. And so these tubes are the molecular scaffolds in the transportation system inside the cells. So these are constantly going on. This is how things move around in our cells, how DNA is made, how things are made. And it's a constant process where you're building up this alpha and beta tubulin and breaking it down. And that's, it's basically like growth of a stem of a plant.
Interesting.
So there's two classes. They're what we call the vinca alkaloids. And ironically, both classes come from plants.
Okay.
So the vinca alkaloids, the most common one is a periwinkle.
That's the name of the drug?
Name of the plant.
Oh, name of the plant.
Yeah.
Okay, I was going to say.
Madagascar periwinkle.
Oh, okay, thank you.
To. A common drug has been vincristine. And so this class of drugs prevents the assembly of these alpha and beta tubulins.
Stops my cranes from forming.
Stops them from forming, yes. Then you have another class of these drugs, antimicrotubules, called taxanes. And they're very important drugs, used quite a bit. And so taxanes are originally derived from the Pacific yew tree.
Okay.
And they do the opposite. They prevent these alpha and beta tubulin chains from disassembling.
Oh. So they're, yes, okay.
So you have this long tube, and it's made, and it's pushed a chromosome under across the side of the cell, but now it can't break down.
Okay.
And so number one, there's a limited resource of these alpha and beta tubulins. They're reused. And then number two, if you have a bunch of structures all over the cell, you're going to gum it up pretty fast, and it's going to commit suicide. So they're quite effective. So the first one, the vinca alkaloids, prevent this alpha and beta tubulin from assembling in the first place, and the taxanes do the opposite. Once it's assembled, they prevent it from being broken down and recycled.
Okay, got it.
And so common drugs are paclitaxel, taxols, and so they are very specific to a certain part of the cell cycle where chromosomes do get exchanged. It's called the boundary of G2 and M. Paclitaxel is.
Okay.
And then docetaxel is another drug of this class, and it works in a different cell cycle. It actually works in the synthesis component, the S phase.
Okay.
And so once again, they're from the Pacific yew tree. Now, the problem with these drugs is they're not water soluble, so they have to be mixed in a certain way to enter the body, and sometimes the drugs or the components that they mix them with can have some side effects in people. So they do tend to have side effects. Ironically, they're natural, but. So then we have what's called the topoisomerase inhibitors. And there's three different classes of these.
Topoisomerase?
Yes. So in order for DNA to be copied, or for transcription to occur, DNA is in a double helix, as you know. It has to be separated. The DNA has to be pulled apart. Two strands have to be pulled apart and unwound, because it's all coiled up in this DNA double helix, as you know. You've seen the double helix.
Oh, yes.
So in order for you to copy this DNA or to create a protein out of the gene that this DNA encodes, you have to separate those two strands.
Okay.
And then you have to unwind those two strands because they're wound up and under tension. And so there's two classes of molecules that do this. They're called topoisomerases. And there's topoisomerase 1 and topoisomerase 2. And so a class of chemotherapy drugs inhibits both of these enzymes.
Mm.
So the first one is topoisomerase 1 inhibitors, a drug that's commonly used called irinotecan. We're seeing its revival. It's being used a lot because it seems to be very effective in a type of colon cancer that other treatments aren't, and those are KRAS mutated colon cancers. So when we see a KRAS mutation in a colon cancer, we always try to recommend that the patient gets an irinotecan based platform.
So we're not quite sure why they're more successful.
Well,
those
there's going to be a
people with that
variety of
mutation?
reasons. I'm sure if we look down at the molecular level, we can explain
It's
it.
unique to each person.
It is.
Okay, got it.
Yes. So irinotecan is actually a synthetic version of a Chinese ornamental plant. I wrote the name down here. It is Camptotheca. Yeah, Camptotheca.
Okay.
I
See if we can
didn't know
find
that.
you a
I didn't know
picture.
the name of that.
Okay. Okay, but that's irinotecan.
Yes.
That's the name you need to know,
Yes.
which is the name of the drug, right?
Yes. And then we have the topoisomerase 2 inhibitors. So that was a topoisomerase 1 inhibitor and the topoisomerase 2 inhibitors. And there are two different classes. They're poisons and catalytic inactivators. So there's two subgroups here.
Okay.
The poisons are etoposide and doxorubicin. And then the catalytic inhibitors, which block the actual activity of topoisomerase 2. There's a drug I'm not aware of. It's called alclarubicin. I've never heard of it before. It's my first.
Not widely prescribed then.
Apparently not.
And what was the first one there that you mentioned two that were specific to the poisons?
Topoisomerase 2 inhibitors. There's poisons and catalytic inhibitors.
And what was some of the drug names for the poisons?
Doxorubicin and etoposide.
Doxorubicin. I knew I'd heard of
And
that
etoposide.
before. Okay. Okay. So, am I right? Am I following along here? We have, is this 3 or are we on 4 here?
We're about to go to 5.
Okay, all right. Okay. All right.
Okay. And so the final class of chemotherapy agents, standard chemotherapy agents, are actually antibiotics. They're called cytotoxic antibiotics. Yeah.
I was not expecting that.
Yeah. And so there's 3 different classes. Well, there's probably a lot more, but 3 main ones. The anthracyclines.
Okay.
And they're doxorubicin and epirubicin.
Didn't we just hear about
Ganirubicin.
doxorubicin
Yes.
over in this
Yes,
other?
we did,
Okay,
yes.
all right.
It's got 2 different roles.
All right.
Yes. So they can cause heart issues, cardiotoxicity, and they also cause something called febrile neutropenia.
That doesn't sound good.
No, it's something.
It sounds painful.
It can be a serious issue.
How are these things working? That's making them have those heart side effects. What are they
Well,
actually
I
doing?
would assume that it's because it has multiple mechanisms versus single mechanisms. I mean, we could get into it, and I could look at the details and find out the exact reason.
Maybe we'll do that another day.
Yes,
Yeah.
that's good. And then we also have a different class called the bleomycins,
Okay.
and then the mitomycin C. Now you might remember mitomycin from the alkylating agents too.
Yes, because I'm remembering everything. I'm going to have to read these notes over about 20 times now, but I do see it. TMZ.
TMZ.
And mitomycin.
TMZ is a tetrazine.
Okay, but yes, those are up in the alkylating agents
Yes,
list. Yes.
exactly.
Okay, got it. Okay, so some of these drugs cross over and are in
They
a
have
few of
multiple
these
mechanisms.
I
yeah.
see. Okay.
And some of them, there's mechanisms
All right.
we don't even understand.
Which is starting to make sense to me, who sees reports go by my desk as to why I might see some of these more than others.
Exactly.
Is that
Yes.
some of them are doing double duty here.
Yeah.
Okay. Okay, so ultimately all chemotherapy works the same way, which is
Interferes with mitosis.
interferes
The cell
with
cycle,
the
yeah.
cell life cycle, That's right. And again, we have these side effects because sometimes just interfering with that cycle produces side effects.
Of course.
And
yes.
then there's the other things that might be mixed with the drug that might give the side effects. And then just some of the other kind of correlated effect on the body.
Yes, exactly.
Okay. Which is, again, understandably why people are so eager to avoid chemotherapy if they can, because we hear about these things.
The side effects, permanent damage, it can damage your nerves too.
Right. But I know that there have been, I know that there have been circumstances where with the use of the precision oncology process and people having more targeted treatment plans or more personalized treatment plans, where they've been able to greatly reduce the amount of chemotherapy they need to have. And the use of other treatments that are more targeted not only provide better outcomes, but really reduce those side effects. Yeah.
And understanding your genetics is really important here. For example, we see this all the time with the platins. Certain mutations, like if you have mutations in BRCA1 or 2 or DNA repair pathway mutations, the platins are very effective. Very effective there.
So thankfully, chemotherapy has existed because there are lots of people alive today because they were able to get that treatment, even if it's not perfect and it has these side effects. It doesn't work for anybody. We're grateful that it's been there.
It was, the first biological approach rather than just doing stuff that medicine has been doing for many, many years. Like, let's face it, 100 years ago, it was leeches and trepanning and things like that. So it's, this is where science was starting to get incorporated into medicine. I think that's very important because, we assume that medicine is based on science, and it is for the most part, but it's a part of science that is not completely science.
Yeah, well, it's constantly growing.
Well, there's a lot of statistics involved that is not science. It's just averages. Let's throw this drug at these people and let's see what's going on here and see how many survive. And this is how many of these indications occurred. If we use the technology that many of these chemotherapy agents were approved today, if we used those sort of clinical trials today for our targeted therapies and immunotherapies, none of these drugs would be approved.
Right.
We would have needed, you need a lot of people to prove that a chemotherapy drug is good because there's so much variation in how these people respond.
I see.
With the targeted therapy, you need a small group of stratified patients that have that mutation.
Right.
You can do a trial, you can do a targeted trial with 40, 50 people.
Wow. Because as you say, the mechanism.
Exactly.
So
with the chemotherapy drugs, you need thousands and thousands, 10,000 people to get proper significance.
Right. And also, I imagine to determine dosage.
Dosage is huge.
Because that's going to take a while to figure out.
Yeah, it was interesting. I was talking with an oncologist a few years ago, and he's been around quite a while. And he says, he said to me, he's got a strong accent, and he says, when we first saw chemotherapy, back in the 70s, we thought, wow, this is really the stuff. This is going to change our treatment. And, he says, we're just so happy about this. He said, so I've seen the sunrise of chemotherapy, and now I'm watching the sunset of chemotherapy. I thought that was so classic, He's been here for the sunrise and the sunset. And boy, have things changed for him.
Yeah, right.
He started, thinking that chemotherapy was going to be it. And now he's dealing with immunotherapy and targeted therapies and, all these different new approaches. So it's been a lot of learning in his lifetime, a lot of upgrading and, just bringing in new information.
I'm sure. And that is the case for all oncologists, really.
It should be. I think it's just gotten too big to leave it on doubly on oncologists and doctors. I think, it's really important that they have a hand. They're not trained in biology. They're not trained in science.
Well, in certain countries, it depends on what country you're in.
I'm not saying an oncologist can't have alternative training in biology. It's just not part of the standard medical training. It's very limited because they're doing pharmacology and they're doing trauma.
Well, I know, for example, you're the expert here. So please, of course, correct me. And in recent conversations with cancer experts in Germany and in Romania and in England, what seems to be the theme heading over into the European part of the world is that there are two very distinct types of oncologists.
Right. Yes.
Which is not the case here
in
Canada, North America, really. But there's like the molecular oncologists who are all about the research, who would be perhaps, again, not as up on things depending on their career and other demands that they have as yourself, but would have a lot of knowledge on these things.
Right.
And then there's the clinical oncologists who are on the front lines. And in those countries, at least in certain facilities, these two types of oncologists work together, and they feed the molecular oncologists feed the information to the clinical oncologists, so they can which is essentially in North America what you and your team do for oncologists.
Exactly.
Yes. So depends on the type of oncologist, but most patients are being seen by the clinical oncologists who wouldn't be as up to date on the latest.
And the oncologists have a really important role in that they're the front lines with the patient. They can see how a patient is responding in real world to a certain combination of drugs. So I don't ever see that position being replaced. I see it being enhanced. They need
more of a support team.
Yeah, they need a support team behind them to help them get through all this mass amount of information that we're getting.
That's right. And ideally, many oncologists are working essentially with one hand tied behind their back because they're not able to access the type of precision diagnostics that you and your team use.
Of course not, no.
So they're not able to really start out with the most personalized treatment plan for people.
Exactly.
So there's a few changes that need to be made to how cancer is treated, particularly, really around the world, but we're talking specifically North America. Yeah. So chemotherapy, anything else that you'd like us to know?
Well, you had some questions on chemotherapy.
Oh, yes. Okay. Absolutely. I do have questions. Thank you very much for reminding me on this. So let me just make sure that you answered that question that we had earlier. Now that I've got so many notes here, and I have, of course, lost the one page that had the most important notes on it.
The secretary.
Oh, okay. So Tabitha, you had asked a question, which we now, if we've watched and paid attention, even if we didn't take notes, we know the answer to. The question was, is all chemotherapy the same?
No.
Yes. Yes, no.
Yes and no.
Yeah, no, you're right, no. Because you said, wait, no, there's 5 different main types of chemotherapy.
Yes,
mechanisms that are used for chemotherapy drugs.
But they all inhibit mitosis.
They all inhibit, okay.
And that's how you define what a chemotherapy agent is. Anti-mitotic agents.
Okay. So our answer, Tabitha, is, well, it depends on the level in which you're looking. Surface level, yes, because they all are these anti-mitosis, but a little bit deeper, there's these 5 different types, and within that there's subgroups and then a bunch of different drugs for each subgroup, it looks like. So there's a lot that goes into deciding which chemotherapy is going to be best for you. Right. And again, when people know their genetics, then that can be even more targeted or more personalized, even with chemotherapy. All right. Okay. So now we have let's see here. So could we just go back? And this is a question that came in from Paul. So let's just answer this. I know that you covered some of this information earlier, but why do you lose your hair with chemotherapy?
Okay. So the main reason is what happens is your hair follicle contains something called a stem cell. And this stem cell constantly produces hair. So your hair is always growing. It doesn't stop growing. And so once again, anything that's constantly growing or rapidly reproducing will be affected by chemotherapy.
It's going to be targeted because that's what the chemotherapies are doing. They're in that anti-mitosis process.
Now, one of the problems with interfering with the cell cycle is if a cell is not going through reproduction, such as a stem cell that produces cancers, then it will not be affected by the drugs. And that is why typically cancer treated with chemotherapy always comes back. is because the stem cells are not actually reproducing.
Because they go to sleep.
They go to sleep, yes.
Yes. Right. And so when they're sleeping, the drugs can't find them.
No. They're not interfering with the reproduction, the cell cycle.
Right.
So, and we know this because when you get chemotherapy, your hair falls out. And if it did affect the stem cells, then your hair would never come back. But as soon as you stop the chemotherapy, your hair starts growing back. And so that's proof that, that at least for the hair follicle, the chemotherapy does not affect the stem cells. In the hair follicle.
Right. And, and again, as you see with the number of recurrences, then that's the same for those cancer stem cells.
So now you don't have to lose your hair. There are certain chemotherapy agents that normally you would lose your hair. That you can take these skull caps, and they have these services in all over the States. It's kind of hard to get them done in Canada. I know the local head nurse where we are has kind of banned these skull caps. And basically what they are is they're frozen caps. You can buy them online. They're single use where you just stick them in a freezer and they freeze up like like one of those ice packs. Or you can actually get ones that are like little refrigeration units, and they constantly keep you cool. And so what they do is they cool off your head while you're getting the chemotherapy, so the blood does not go there. Now, obviously, the biggest concern was, well, what if you get a tumor in your brain? But really, it only affects the skin layer.
Right.
And so most of the tumors are not going to affect.
So the value of the hat, or the what is it called? A skull cap.
Skull cap. Yeah.
The value of that is if you want to not lose your hair.
Yeah,
right.
Yeah.
Oh wow.
And they work really well. They work quite well. Now they don't work for every drug, and you don't want to have it for every type of cancer. There's obviously going to be exceptions. Sure. But I think a lot of people can benefit from this, and it's a big thing in the States. In fact, they have these services called cappies, and they just run around. They're like couriers. They run around with these ice chests and go from hospital to hospital and drop off these ice packs and pick up the old warmed up ice packs and so on.
Wow!
And you could buy these online. You can buy these skull caps online and put them in your freezer.
Do you remember how much they were? They're not more than a couple $100.
No, they're I've seen them as cheap as $50.
$50.
Yeah.
Okay. Give or take.
Yeah.
So.
Now the problem is some chemotherapy units won't let you use them. They say they get in the way. The ice buckets get in the way, or
If that's the case, you can call us, because that's our job, is to advocate for you.
Yes.
Yeah. But that's wonderful. What a wonderful thing to be able to have.
It's not very common in Canada right now, which is surprising. It's pretty big all over.
The times, which is a topic for another day. But that's good. At least it's out there. There's data being collected about how well these things work. It won't be long before it's something that we have in order.
There's a couple companies right now that have been fighting with Health Canada for a few years to get their products covered.
Good. Well, it takes about a decade. So
it does. 10 years.
Hang in there, people.
10 years we'll be able to keep our hair.
Yes. Okay. So Liz was wondering, how long does it take for chemotherapy to start working?
As soon as it enters the body.
Okay.
Typically.
All right.
Yeah, very quickly.
Right. And it doesn't stay in the body very long.
No. And that's the problem with chemotherapy is you can only have so much of it. I mean, obviously it's going to affect any rapidly reproducing cell whenever you give it to them, give it to a person. But after a while, you just can't, your body just can't tolerate it.
Yeah.
So that's the reason. If your body could tolerate it, then, it would be curative in some sense, because anytime the tumor comes back, you just retake it.
Right.
But there's a limit to how much chemotherapy you can have.
Right. But on that concept of cancer being something that, you just take a pill for every now and then, we are rapidly entering that phase of cancer treatment where it is something that is chronic, but chronic easily disease, treatable and like maybe a type 2 diabetes kind of thing.
Exactly.
When that's, to me, the most exciting thing about cancer right now.
Yeah, we'll definitely be there soon.
Yes, that is very exciting. And again, back to what we were talking about at the start of the hour with the prevention, being able to test for certain genetic markers and make sure that you're doing everything you can for prevention, catching cancer early, taking one of these fancy pills. Wow, that's going to make such a huge difference to how we won't have that understandable trauma response when we hear about a cancer diagnosis. It'll be, okay, well, where's the prescription? I'll head off, go like blood pressure meds or things like that, perhaps. Mm-hmm. And yeah, not that far off. Here. Okay, one question left, and then I'll let you go. Thank you very much for coming in and telling us all about chemo. How will I know if the chemotherapy is working?
Well, traditionally that's a long question.
Well, do your best. Give us a list. You're good at making these lists.
Typically what you see is the tumor shrinking.
Okay,
over
so you'd
time.
see it like on a scan.
Yeah,
You'd have
on
to
a
have
scan,
scans.
imaging.
Okay.
If you have a PET CT, you'd see the SUV going down. It's a serum uptake value. You'd see that going down. On liquid biopsies, you would see on a standard liquid biopsy that does not differentiate between the source of the DNA. In other words, looks at all of the DNA in the blood. During the chemotherapy, you'd see an initial increase in the mutation that you're tracking. And that's because the tumor cells are dying and releasing their DNA into the blood. And then a few weeks later, you'd see a significant reduction in the amount of the mutation.
Okay.
With the exosome-based liquid biopsies that we use, right away you see the reduction.
Right. You're looking at the data that matters.
Exactly.
Got it. Okay, so so it really depends on how your doctor's monitoring you, or how you've chosen to monitor your cancer care. A CT scan, not so accurate.
No.
Not recommended.
And that's because you can have the death of a tumor, but it would still remain intact. And it takes a while for your body to remove it, if it ever removes it.
Right. So if your doctor is just determining the success of your cancer care based on the size of the mass on a CT scan, that's not a very accurate assessment. A PET CT would be better. Yeah. Looking at those SUV levels, and then as you say, liquid.
Seeing if it's necrotic tissue.
Right, and then the exosome-based liquid biopsy. Those are the best ways to know, as well as your own self-report. How are you feeling? What are you noticing? There'll be certainly you will have had certain side effects or symptoms as a result of your cancer, and how are you noticing any exacerbation or lessening of those?
Well, yeah, I guess so. Some people are really tough. I speak with people and they've got stage 4 cancer, and how are you feeling? Oh, fine. I feel good. I feel great. I don't even know I've got cancer. If the doctor hadn't told me. Yeah, exactly.
Yes, that is true.
And then you have people that are considered cancer-free and can't get out of bed because of IBS or something like that.
Which, right.
So I don't like going with how you feel.
Your own self-report.
No.
No. I'm just recalling numerous conversations with people once they started, say, immunotherapies or targeted therapies, and how they are, how they notice how much more energy they have, right? Just how much better they're feeling.
Definitely, yes.
But I understand. We definitely want more clinical data than that to determine that your chemotherapy is working for sure. And with the CT scans, it takes about 3 months to be able to start to have some of that information about whether your tumor is shrinking. And again, not very accurate in contrast to a PET CT. And with the liquid biopsies, let's say I started treatment today, how long would it take for you to tell me with a liquid biopsy if my treatment was working?
Literally probably about within 10 days.
Within 10 days.
10 days to 2 weeks.
Okay. So I could know
very quickly.
Pretty quickly if I'm on the right treatment and how well it's
working. And that's very important.
It is very important that you're on the right treatment, but also just for peace of mind and reassurance to know that things are working.
Well, especially if you're on an expensive drug.
Right. Yes, there is that. Yeah.
Thank you for watching Ketome TV. Subscribe below and stay informed.